Can I start now?
Yeah, sure. It's 28 including me or 28? There's one more person who's not here. It's 28 including me or is there one more person not here?
Supposed to be 29, including doctor. So one more person.
Orang lagi hilang. Okay. You guys in campus, is it? You guys in your rooms kat campus, is it?
Yes.
Yes, doctor.
Nak tunggu ke apa? There's one more person. Oh, nak start.
Dah cukup dah. Okay, so I'll start. So, good morning to Dr. Chan and also my colleagues. So today, me and Abi will present on chat with breathlessness as well as chat with sinus. So I'll start first. So for the chat with breathlessness, so for the definition, breathlessness, or we can also say a shortness of breath or dyspnea, is basically increased flow of breathing or the alteration of the pattern of the breathing, which is mentioned in sunflower. And in up to date, we mentioned that dyspnea is a subjective experience of breathing discomfort. And it is qualitative in nature, basically is variable from person to person. And also in Nelson, we mentioned that dyspnea is also considered as one of the symptoms of respiratory distress. So we can also mention that dyspnea is respiratory distress. Okay, so for the causes of breathlessness or respiratory distress, I divided into age, anatomy, and yeah. So for the age-related causes of respiratory distress, can be divided to full-term unit, infant to toddler, children, and also adolescent. So we focus on the common causes. There are a lot of them, but for the full-term units, the most common is meconium exploration pneumonia. And for the infant and toddler, the topmost is the viral pneumonia, bacterial pneumonia, and also aspiration. And for older children, pneumonia and asthma are the common causes of respiratory distress. Same goes with the adolescent. And this. Yes, so this is the causes in terms of anatomy. Can be divided into expiratory as well as
I'm sorry, Anis.
Yes?
Sorry, Doctor. Can you adjust your mic? Because I think there are some noises. Oh, okay, it's better now.
Okay. Is it
Ada
better?
balik. Ada noise.
Ada balik.
Ada noise.
Mana? Okay ke?
Ada background noise.
Yeah, ada background noise.
Sebab
Mic.
my earphone dia tak ada mic. So I don't know where. Kat mana problem dia. Sekarang ni okay tak? Better lah.
Anis just kata cuba tak guna earphone.
Oh.
Macam okay.
Dengar ke? Dengar ke?
Dengar. Tapi tak apalah kot.
Sebab speaker
Ada
kita
earphone tak?
so dia problem.
Anis, ada earphone tak?
Ya? Speaker laptop ni pecah, so kalau tak pakai earphone dia tak dengar sangat. Kalau tak lah, apa-apa just stop ni lah kalau tak dengar. So for the causes of respiratory distress can be divided into intrathoracic and also extrathoracic. So for the intrathoracic, can further divide it into pulmonary and also cardiac. And so for the pulmonary, as what you mentioned in up to date, you mentioned that for pulmonary, it depends on these three things. First is the ventilation, second is the perfusion, and third is gas exchange. So any alteration to these three things, it can cause a respiratory distress to the patient. So for example, for the ventilation, there will be disruption in the passage of the airway. For example, in foreign body expiration, so there will be impaired ventilation and it can cause respiratory distress to the patient. Or for example, in patient with pleural effusion, so there will be disruption to the gas exchange. So it also can cause respiratory resuscitation. Same goes with pulmonary embolism. It will affect the perfusion towards the airway. So this also can cause respiratory distress. So there is a lot in the list. And for the cardiac, there is myocarditis or cardiomyopathy, and also congenital heart disease and congestive heart failure also can cause respiratory distress. For the nervous system, for example, meningitis or any shock or sepsis to the patient can also cause respiratory distress or breathlessness, or metabolic causes, for example, acidosis or ketoacidosis in diabetic or in type 1 diabetic patients. So lesion of upper airway, for example, there is formation of cysts or wet that prevent the air from circulating well, or for the miscellaneous, for example, abdominal masses or anemia. So this is another classification. The non-pulmonary causes. So this is in Nelson. They also mention about the mechanism. For example, for the cardiovascular system, example is left to right shunt or congestive heart failure or cardiac shock. So the mechanism mentioned is that when there is left to right shunt, there will be increase in the pulmonary, there will be pulmonary congestion. So later it can lead to pulmonary hypertension, which can cause the patient to be breathless. Or for example, metabolic acidosis, for example, in congestive heart failure, later it can cause kidney injury, which later can also lead to metabolic acidosis. So when there is metabolic acidosis, the chemoreceptors, the peripheral and also the central chemoreceptors will detect there will be there will be low pH or high carbon dioxide. So later it can stimulate the respiratory center for the patient to increase in breathing, so that the patient can excrete more carbon dioxide. So for the bioreceptor stimulation, from what I understand, for example, in cardiac shock, there will be low in blood pressure. So when there is low in blood pressure, the bioreceptor reflex will be diminished. So when this reflex is diminished, the higher center will stimulate the sympathetic activity to increase the cardiac output, and as well as stimulate the adrenal gland to produce more epinephrine and also norepinephrine. So the patient, so the outcome will be when there is increase in cardiac output, there will be increase in blood pressure, as well as when there is increase in sympathetic activity, the patient also can be breathless. Okay. So for the central nervous system, when there is alteration to the brainstem, we also can, because brainstem is the one that controls the respiration. So when there is pathology to the area, it also can cause the patient to have respiratory distress. And same goes with the metabolic causes. Because of the acidosis, you stimulate the chemoreceptors later on, can cause patient to be breathless. Okay. So for the history, when you approach a patient that have a complaint of breathlessness, so how do you approach this kind of patient? First, with regards to the onset, the duration of the chronicity, we can differentiate. We can ask, is it abrupt or gradual? So if it is abrupt or sudden, it's suggestive more towards upper airway condition. For example, foreign body aspiration, or the patient had anaphylactic reaction, previously had underlying allergy, or the patient had sudden spontaneous pneumothorax, or pleural-effusion, or pulmonary embolism. And for the gradual onset, it's more towards something that is insidious, or for example, infection, anemic condition, or patient in failure. Alright. And also we need to ask whether is this the first episode or it already has been recurring, which suggests more opportunity. Okay, so for aggravating factors, we can also ask about exposure to house dust mite or cigarette smoking, which can precipitate patients that have asthma to have breathlessness, or dyspnea on exertion, which also suggestive of asthma, or any history of playing unsupervised ataupun has history of choking. This is suggestive of patients to have a foreign body aspiration, because when they are playing unsupervised, probably they take something without notice. And the relieving factors, for example, does the patient, the breathlessness, does it respond to any therapy, or the wheezing, does it respond to any therapy? For example, in asthma, they may respond post having the bronchodilator. But in patient that wheezing due to foreign body aspiration, even though they took bronchodilator, for example, the symptom may still persist because there is still the pathology there. Okay, and also in the book mentioned that in certain patients they will sit in this position, the sniffing position, which is to maximize the airway patency. And this is usually happen if there is upper airway obstruction. So later in the physical examination, we should review what is sniffing position. Okay. So for the associated symptoms, you can also ask about the respiratory symptoms. So is if there is any cold symptom, for example, sore throat or runny nose, which can indicate upper respiratory tract infection. Or does the patient have a characteristic cough, for example, barking cough, which can suggest cold. If there is you can also ask the patient if there is any, does the mother notice any retraction, muscle retraction, especially over the supraclavicular and suprasternal, which suggestive of upper airway. So usually the intercostal and the lower down is more towards lower airway, but for supraclavicular and suprasternal can be suggestive of upper airway obstruction. So with regards to colour, you can also ask the mother, does she notice any looking like pale or blue discoloration? So if pale, it may indicate anemia, or if blue discoloration, it can indicate there is probably reducing, there is high deoxygenated blood, for example, in congenital heart disease. You also can ask about respiratory effort. If the mother look at the children, there is poor effort, so it could be muscular dystrophy. Or we can ask about the change in the voice. Is it muffled or hoarse voice? Because if there is changes to the voice, usually it's suggestive of upper airway obstruction. Because lower airway, usually they typically don't have any changes to the voice, the character of the voice. Okay. So for the systemic symptoms, you can ask about fever, which can indicate infective causes. Or you can also ask about hydration status, the intake and the output. Because shock can also be one of the causes of breathlessness, or if the patient is having severe breathlessness, it can also impair the hydration status of the patient. And then we also need to ask about the weight loss, or if there is any failure to gain weight during the development of the develop, because this could indicate either inborn error metabolism or in a chronic condition, for example, like congestive heart failure, they can impair the growth. So for abdominal pain, you can ask about abdominal pain. Abdominal pain may indicate either its abdominal pathology, for example, there is obstruction or infection going on that cause the patient to be breathless, or it is actually a recurrent pain. The patient had a lobar pneumonia, sorry, basilar pneumonia, which irritate the diaphragm that can cause recurrent pain to the abdominal area. Or the patient actually had a metabolic abnormality, for example, diabetic acidosis, which also can have abdominal pain and also can have breathlessness. For chest pain, it may indicate underlying spontaneous pneumothorax or there is cardiac pneumonia. So that is symptom wise, and this is a group based on the disease. This can be later. So, other history. It also asks about the exposure or environmental factors. For example, exposure to fire. So when there is fire, the breathlessness can be due to the direct injury, due to the thermal injury to the airway, or because of the byproduct of the fire itself, which is carbon monoxide and also cyanide. So as you know, the carbon monoxide has higher higher affinity compared to higher affinity, so later our body, the oxygen cannot be released to the tissue, so it can cause also breathlessness. Same goes with cyanide. And then that's about fire, and you also need to ask the patient if there is any exposure to allergen or any history of allergy, which and the patient also can manifest with anaphylaxis features, for example, like swelling of the mouth or any urticaria or the rash. The urticaria rash, the one that is the ring, the anaphylaxis feature. Okay. And then another exposure could be exposure to smoke. For example, is asthma patient, if the family member or the family member is smoking, it can also trigger the patient to have breathlessness. And for the trauma, because trauma can also lead to breathlessness. For example, pneumothorax, platelets, cardiac tamponade, and also abdominal injury. Or if there's any trauma to the head, it also can it also can affect the respiratory system and cause the patient to be breathless. So of course, in a pediatric patient, we also need to exclude the non-accidental injury. And the last oral intake, in the book you mentioned that we need to also ask about last oral intake because we might think of this of common experience. So other history, for the past medical history, we need to ask if there is any previous episode, similar episode, and if there is any treatment used to treat the episode previously. So maybe if the medication, if the previous episode it responds to the same medication, then probably this episode it can also use the same medication. Or you can also ask for specific chronic medical condition. For example, if the patient had underlying hematological disease, for example, sickle cell disease, could be the patient currently having the acute chest syndrome, or if the patient had underlying chronic asthma or nephrotic syndrome, patient can come with fluid overload and become breathless. Or if there is any recurrent chest infection. And we can also ask about history of gastroesophageal reflux disease, because this can precipitate patient who is having aspiration pneumonia. And also previous intubation. For the previous intubation, which can precipitate patient to have recurrent pneumonia. For example, in the first history, if the patient is premature or had history of intubation, which can predispose patient to having BPD, bronchopulmonary dysplasia. So it also can come with recurrent infection and disease. For the birth history, prematurity, which can lead to congenital anomalies, for example, of the lung and heart, for example, Down syndrome. And if the mother having gestational diabetes mellitus, because it is a risk factor for the baby to have congenital heart disease. So for the immunohistory is important, especially for the hemophilus influenza vaccine, HIV vaccine, which for the patient that don't take this vaccine, they have high risk of diarrhea epiglottitis. And if the patient had history of non-compliance to immunization, for example, for BCG, the patient may be disposed towards family tuberculosis. So for family history, can ask about the history of asthma, history of allergy or atopy, if there is any congenital heart disease in the family or cardiovascular disease in the family, or any syndromes that inherited within the family, or if there is any history of diabetes mellitus in the family as well. So for the social history, you need to ask about the environmental factors, right? The housing area, the house, and how about their performance, how they are, especially if it's chronic, how it affects their school performance, and how do they having sport activities. Does it interfere with their life or not? And if there is any travel history, which can be suggestive of risk of infection. So for the physical examination, um, generally we can look for whether the patient is alert or conscious or not. In the book, you mentioned that if the patient is agitated or somnolent, more like drowsy, it may indicate that the patient is actually having severe respiratory distress and impending respiratory failure. So we need to be aware of the consciousness of the patient. If the patient is ill-looking, suggestive of infection, for example, in epiglottitis, usually the patient is very septic looking, very ill-looking. And for this, this is the specific posture. As the patient is in sniffing posture, which I will show later. And does the patient have a morphologic feature that's suggestive of having Down syndrome or Turner syndrome? Okay. You can also look for the degree of cyanosis as well as the nutritional status of the patient. Because in, for example, in congestive heart failure or chronic asthma, the patient can have respiratory growth. Okay. So this is the sniffing position. So if usually when the patient had upper airway obstruction, they will be in this sniffing position because it basically kind of like align the airway to make the airway in a straight line so that the breathing is better. So the sniffing position is either you put a towel at the upper shoulder or below the occiput. And then the glabella and the chin, as you can see in the picture, you need to be horizontally aligned. And the neck is wide and open adequately, not too hyperextended or too flat. And the external auditory meatus is in line with the suprasternal. So this is the sniffing position. Because in children, their occiput is bigger. So when they are in supine position, they tend to be in a hyperextended position. The occiput tends to be lower down. So the neck will be hyperextended. And as you can see in the picture, can you see my cursor? Can you see my cursor?
Yes, Anis.
Okay. So for example, in this position, the patient is hyperextended position. this is hyperextended. So when there is hyperextended of the neck, then the airway will not be in a completely straight line. So it makes it harder for them to breathe. So if in the sniffing position, the airway is aligned better, so it can help with the respiration. But then if the head is too flat, it also can obstruct the airflow. So that's why the sleeping position is better. Mm. So as we mentioned before, in the general examination, we need to look for the any morphological features suggestive of syndrome. For example, in Down syndrome, you can have this typical facing with the epicanthic fold and a slanted corporal fissure. So slanted corporal fissure means that the nasal fissure is lower compared to the temporal fissure. And there is also in the eyes, you can see there is a brush spot. And for the limbs, there is single palmatis, and the fifth digit is usually can you see the quite it's not straight lah. It's a bit not flat, but I don't remember the term. There is a apology lah to the digit, the finger digit. Okay. And there is a wide center gap between the first toe and the second toe. Okay. So that is for Down syndrome. For Turner syndrome, usually they are short stature and have a wet neck speed, wet neck. The neck appears larger, and for example, the nipple line is widely spaced. And also, there is also other features of Turner syndrome. So there is okay, so for the next general inspection, we also need to look at the respiratory pattern. So there are few respiratory patterns. First is rapid and shallow breathing with prolonged exhalation. When there is prolonged exhalation, means there is an air trapping. For example, in asthma or foreign body expiration. So when there is pathology there, so during expiration, it takes more time compared to normal to properly exhale. So that's why there will be prolonged exhalation. Okay. Or the patient is in pain, so also there will be prolonged exhalation. And the second is small respiration. Deep regular labeled breathing, this indicates metabolic acidosis. Or the change stroke respiration is more towards CNS pathology. For example, CNS immaturity in premature baby, the higher center is still not fully developed, or if there is inadequate cerebral perfusion or brain injury or increased intracerebral pressure, all of these conditions can present with change stroke respiration. And the last one is paradoxical breathing. This is could be suggestive of paradoxical breathing, meaning during inspiration, the 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 chest is lowered down and the abdomen is raised up. So should be both. Should be is the other way around. So this indicates respiratory fatigue or muscle weakness. So this is the signs of respiratory distress. There are disappearing cyanosis, grunting, head bobbing. So for head bobbing is the extension of the head and also the neck during inhalation. And during exhalation, the head and neck will fall forward again. This indicates that the patient is when the patient is very fatigued because of respiratory distress, and this is actually poor a poor feature of respiratory distress. Meaning it's already severe respiratory distress, the patient will present with head bobbing and head blanking. Other signs of respiratory distress is retraction of muscle. For example, the suprasternal, intercostal, and subcostal muscle, which indicates worsening in respiratory distress. And the last one is stridor and also weakness. That's for general examination. For the vital signs, For the respiratory rate, if the patient is asthmatic, it may indicate patient having respiratory disease or because of fever or because of the patient is crying or also other causes, for example, cardiac disease and metabolic acidosis. If the patient had apnea or bradypnea, it can be due to respiratory muscle fatigue, or in premature neonates, it is because of the higher center is still immature, so they can have sudden apnea. And in young patients, apnea or bradypnea usually can be due to infection, for example, bronchiolitis. Or in older children, it can be due to choking, head trauma, or poisoning. So for the high risk tachycardia, it can be because of respiratory distress or the patient is also in dehydration, or bradycardia, which is usually a late sign and it can later progress into cardiopulmonary arrest. This is the respiratory rate based on age, which can be in the protocol. So for anthropometric measurement, as I mentioned before, you need to chart the weight, the height, and if there is any stunted growth, it can be because of severe asthma or heart failure. So for the respiratory examination on inspection, you can look at the size, at the shape of the chest, can be pectus excavatum or pectus stenotum, or it could be a barrel chest, which suggestive of patient had hyperinflation, for example in asthma. Or we can also look for Harrison sulcus, which indicates in chronic asthma because there is a chronic because when the chest is always hyperinflated and the diaphragm keeps on contracting, so later it can cause this Harrison sulcus. So that's for inspection. For palpation, also palpation, if there's any tracheal deviation or this space affects beat, it can indicate that there is a mediastinal shift, for example, in ventricular. Or we can also palpate for subcutaneous emphysema, which can indicate there is a pulmonary edema. So for percussion, dullness indicates consolidation or atelectasis, or probably there is fluid diffusion. So usually fluid diffusion will present with stony dullness. And if there is hyperresonance, there could be hyperinflation. So for auscultation, these are two added sounds that we can examine during the lung examination. So wheezing is a continuous high-pitched and musical, usually indicative of lower airway infiltration obstruction, for example in asthma. Or if the patient, when it auscultate, there is a prolonged expiratory phase, it may indicate there is obstructed lower airway. Or stridor, usually more towards after airway obstruction. So crisis or crepitating, usually it is during inspiratory, and it occurs because of the opening of the airway or the alveoli, which is previously already closed during the expiration. And ronca is a continuous sound, more or less like wheezing, is just that it is more lower pitch, and it also indicates lower airway. Okay. So apart from respiratory examination, to exclude other causes from other systems. So for example, for CNS, if there's any autoimmune disease, it can also be due to the infection or any head trauma, any toxic ingestion, or hyperammonia because of when there is high amount of ammonia, it can cause insecurity. Also can affect the status or if the patient has seizure. So for the cardiovascular examination, memory, jugular venous distension, cardiology, and hyperkinesia, all of this may indicate the patient is in failure, which can also present with sickness. For GI skin, if there is any abdominal tenderness or abdominal distension, and for endocrine, weight loss, dehydration, and fatigue and abdominal pain may indicate diabetic ketoacidosis. So for next one is allergy. The patient may have urticaria and also facial swelling and also oropharyngeal edema, which later can patient can present to you to the patient. So for the investigation, for the backside, you can look cross oximetry to look at the oxygen level. And for the lab investigation, you can do venous or arterial blood vessels to look for the oxygen or if there's any presence of metabolic acidosis. And other lab investigation is depends on each differential diagnosis that we want to work out. Okay. Okay. So for the imaging, sorry. So for the imaging, can do chest X-ray, and from the chest X-ray, you can look for any lung abnormalities, if there is any consolidation or if there is any effusion, or we can also look for any airway obstruction if it is ready occurred. Okay. And for bony thorax, the ribs, it is probably because in trauma patient there will be a plate test, or we can see broken segment of the ribs, or the vertebral abnormality probably because of scoliosis, which can also impair the thoracic cavity. Also, patient can present breathlessness. And from the chest X-ray itself, we can also look for cardiomegaly, pulmonary edema, and also pericardial effusion, which may be suggestive of heart failure. And also you can look for the blood vessel. So for the ultrasound, for the pulmonary ultrasound, you can see any features of pneumothorax or effusion or other fluid accumulation, for example, blood pneumothorax or pulmonary edema. The echocardiogram is to assess if there is any cardiac component or any structural abnormality or functional abnormality of the heart. And for the CT scan, you can look for any mediastinal abnormalities or mediastinal lesions, or if there is any bronchiectasis, which can also be shown breathlessness. And for MRI, you can search for blood vessel anatomy. If there is any alteration to the blood vessel, for example, in congenital heart disease, and so on. And also in the book mentioned about the endoscopic evaluation of airways. There are two. First is nasopharyngoscope and also bronchoscopy. So for the nasopharyngoscope, it is to assess the adenoid size, the nasal passage frequency, and also if there is any elongated glottis. Also, it can evaluate if there is any stridor and assess the vocal spot. So maybe there is any upper air obstruction, so we can use nasopharyngoscopy. And for bronchoscopy, there are two types, flexible and also rigid. It can be used to identify airway abnormalities, or at the same time, it can also take the sample for culture. And for the rigid bronchoscopy, it can be used to remove the foreign body as well. So for the principle of measurement, basically, in general, we need to stabilize the patient first according to the ABC. So for the airway, we need to ensure a patent airway. So if the patient is unresponsive, we need to do the jaw thrust or the chin maneuver. And when we already establish this position, we need to clear the airway by doing suction. And if still this positioning doesn't relieve the obstruction, then we need to opt for a jump. For example, the oropharyngeal airway or the nasopharyngeal airway. For the breathing, as we already include a patent airway, then we need to provide necessary oxygen support if the patient needs the oxygen. We need to monitor the oxygenation by pulse oximetry. The last one is circulation. We need to monitor the heart rate and also the rhythm, and establish vascular access for fluid administration or medication for resuscitation. this is the picture. The left one is the oropharyngeal airway, and the right one is the nasopharyngeal. So the difference is that the nasopharyngeal is it is flexible compared to the oropharynx. The oropharyngeal it is better for patient that is unresponsive or unconscious because it can cause gap reflex and also uncomfortable breathing because it touches the soft palate. Okay, so that is the general approach of dealing with breathlessness. And now I'm going to discuss about asthma and also pneumonia. But then I will only highlight the important points. So for asthma, it is a chronic airway inflammation that leads to increase in airway responsiveness. So how do we diagnose asthma in pediatric patients? It's based on the history and also the presence of airway reversibility after administering a bronchodilator. But then this is for older children. In younger children, based on history, examination and also family history. So for asthma, as I mentioned before, so the history is based on dyspnea, wheezing, chest tightening, or coughing. And we also need to ask about the pattern of the symptoms. Is it episodic? And usually asthma is episodic, and uh, there is a free period from symptoms. And then is it diurnal or does the symptom exaggerated after or during exercise? And for the precipitating factors, usually asthma is precipitated by common cold or allergen, or if there is any cold weather or irritants, for example, smoke, haze, strong smells, or exhaust fumes. So according to the pediatric protocol, um, um, there is a guideline or suggestion in the history what should we ask. So we need to ask about previous hospital admission and what treatment is prescribed before and how is the response of the patient to the treatment, and if there is any history of exacerbations or history of apathy. And for the family history, we need to ask family history of apathy like I mentioned before. And for the social history, we need to ask about the environment and the impact of the asthma to the life of the patient. So for the physical examination for chronic illness, usually you can notice there is rising sulfide, hyperinflated chest, on the skin there is eczema or dry skin, and on the lungs there is hypertrophic edema. And for acute exacerbation, basically the respiratory distress symptoms, drowsiness, cyanosis, the tachycardia and tachypnea, and everything. Okay. So in younger patients, there is also features that suggestive of asthma. For example, cough, there is associated with wheeze and also breathlessness. And the cough is usually in the absence of infection. Usually the cough is associated with laughing, crying, or any exposure to the smoke. And the patient or the children can have cough. And the children also can have recurring wheezing, either during sleeps or associated with triggers. For example, when they are doing activities, playing around, or laughing with their friends, or laughing with their family, laughing with the family, or crying, or if there's any exposure to the smoke. They also can have shortness of breath while doing the daily activity and also reducing activity. So they tend to not to run, not to play with other children because they have this preference. And also there is a positive family history of allergic disease or atopy. So this can be suggestive of the patient may have asthma. So in patient that is less than 5 years old, we use this approach, which is the probability of asthma in this patient. So based on these characteristics, the duration of symptoms, the number of exacerbation, the interval symptoms, and also the family history of atopy, based on these characteristics, you divide them into whether they have higher probability of asthma, moderate or low. So, if the children, for example, have higher probability of getting asthma, then probably the doctor will start the patient on trial of corticosteroid, SCS. So for moderate, probably the doctor will wait first before starting the medication. And for the patient with low risk, the doctor needs to rule out other diagnosis compared to asthma. So in older children, 6 years and older, if they are newly diagnosed with asthma, then we need to categorize them into the severity of the asthma, whether is it intermittent or persistent. Persistent, there is mild, moderate, and so severe. So when we already specify them into the severity of the asthma, then we can start them on the medication based on the severity. And during follow-up, we need to assess the asthma control, the compliance, and also educate them about asthma. So for the asthma control, sorry, so for the asthma control, so severity is when the patient is newly diagnosed with asthma, and during follow-up, we need to assess their level of control because depends on this level of control, then we will step up or step down the current treatment. So the level of control is based on the daytime asthma symptoms, any nocturnal symptoms, any reliever needed, or any activity needed due to asthma. So based on the symptoms, based on the control, so if the patient already compliant with the medication and using the right technique, but still the asthma symptom is not controlled, then we need to step up according to this table. So for the asthma education, we need to make them understand about the asthma injectable, and we emphasize them on the compliance of therapy, and also give them the written asthma action plan. So this is the written asthma action plan. It is basically for the doctor to give them for them to know what is their current status of the asthma and what they need to do if there is worsening symptoms. So what they need to do and what they need to take and when they should go to the clinic or to the hospital based on this written asthma plan. So basically, the doctor wants to plan to the patient to make a small adjustment to their current treatment according to their current status based on the symptoms as well as the PFR reading. So that is for patient with chronic asthma. For patient with acute asthma, during the acute attack, you need to classify them into mild, moderate, and severe or life-threatening based on three parameters, based on the symptoms, signs, and also investigation. So symptoms is based on their breathlessness and their ability to talk, whether in full sentence or phrases, and about the signs, whether they are alert or agitated, or are they drowsy, are they tachypneic or very poor respiratory effort, or if there is any other respiratory distress sign, for example, muscle retraction, any wheeze, or any increase in pulse rate. For the signs, we look for SpO2 and also the PFR level. So based on this parameter, we classify them into the severity of current attack, and we will manage them according to this algorithm. The last one is pneumonia. So pneumonia is clinically divided into bronchopneumonia and also lobar pneumonia. So basically, bronchopneumonia is a bright illness with cough, and they also have respiratory distress. generalized on X-ray, you can see there is generalized consolidation. For lobar, it's similar, but it's just that on radiograph there is only local consolidation, not generalized. So for the etiology, mainly is virus, especially in younger children. For example, respiratory syncytial virus, but for older children, usually it's bacterial in origin, and this is divided according to age. And for school-going children, usually common organisms are the atypical organisms. For example, mycoplasma and also pneumonia. So for the clinical features, as mentioned previously, fever, rapid breathing, and cough, and usually is preceded by UTI, and it can also associated with lethargy and also poor feeding. So for the physical examination, there is respiratory distressing signs as follows. And on the respiratory examination, there will be dullness and percussion, can be also on auscultation, there will be decrease in breath sound and also bronchial breathing. But then, not all patients can present with this. But usually there will be postcritus and aspiratus postcritus and auscultate over the body. So for the investigation, it will be chest X-ray, especially when there is clinical features that is suggestive of pneumonia. And then white cell count, usually the neutrophils is high, which is suggestive of bacteria. And if there is leukopenia, it could be because viral in origin or there is ongoing infection. And other than this blood count, we can also do blood culture sensitivity to know the pathogen for antibiotic later on, or if the patient had fluid effusion, you can also tap for and send for testing sensitivity and also analysis. Bedside investigation, you can do post-oximetry. So for the management, antibiotics in the protocol, this depends on which pathogen. There are few choices of antibiotics. And other than antibiotics, we can also give supportive treatment. We can give fluids to prevent dehydration, to correct any dehydration. Or if the patient is in pain, we can give anesthesia. And we also need to maintain the oxygen for more than 95%. And we can also give paracetamol to control the temperature to reduce the discomfort to the patient. And lastly, we can give chest physiotherapy to assist to remove the situation. So that is my references. Any questions? Is there any questions? Yes?
May I ask, the terms of status asthmaticus, is it the same with the acute exacerbation of asthma? Because the terms are already being omitted from PRITS protocol, so I wonder if we still using that terms.
I'm not sure. Is there anybody from the floor can offer their answer? Or probably Dr. Can respond to this question.
I think status at... Hi guys. Boleh dengar ke tak? Guys.
Boleh doktor.
Yeah. Okay, because I'm using two screens actually. I'm using my phone and the PC as well. Sebab mic PC tu a bit crazy and right now my mic My mouse also crazy. Okay, never mind. Status asthmaticus actually is an old term lah. So usually nowadays we just say whether it's acute, severe exacerbation of bronchial asthma. I think in terms of medical students, I mean, as long as you know what is severe and acute exacerbation, how to identify an acute severe exacerbation of bronchial asthma is more important than you memorizing the terminology. Okay, but as it is nowadays, we don't tend to say status asthmaticus. We tend to say severe acute exacerbation. Okay.
Okay, thank you, Doctor.
Wait, I'm trying to share some videos, but my mouse has gone crazy. Give me a second. Now, the thing about this is that it's very long, and then because this topic is more of an approach based, so it's more of during history, what do you look for, how do you differentiate stuff. So it is more of like, if you get a child with breathlessness, is it an acute thing or a chronic thing? If it's an acute thing, especially in the between the ages of the younger kids who are toddlers, like 2 to 3 years old, kids that's 1 year old who still tend to put stuff into their mouth. So you're more worried about things like foreign body inhalation. If it's a few days old kind of thing with a history of fever, then you're worried about whether it's an infection thing. If it's an acute breathlessness on the background of intermittent episodes of breathlessness chronically, then you obviously think about asthma, right? Let's see. Give me 2 minutes, I'm going to go and get a battery. Yeah.
Guys, you guys continue your CVS first. My son's hamster has gone on the list.
Okay, Doctor.
Guys?
Okay, Doctor. I'll continue with
Heard me, right?
presentation.
You guys continue with the CVS for a while because my son's hamster has gone missing.
Okay, Doctor.
Okay? Okay, you guys continue first. Just continue the CVS for a while.
Can you see my slide? Yes.
Yep.
Okay, so today my name is Abir binti Burhanuddin. I will be presenting on child with cyanosis. So this are the outline of my presentation. That from introduction, types of cyanosis, the mechanism of cyanosis, and then the etiology of cyanosis, the clinical approach, principle of management, and last but not least is the summary. Okay. For the cyanosis, so let us define cyanosis. So cyanosis is bluish purple discoloration of the tissue due to increase in concentration of deoxygenated hemoglobin in the capillary bed. So here I provide definition of hypoxia, hypoxemia, anemia, and polycythemia so that it will not be confused. So hypoxia is low oxygen supply to tissue. Hypoxemia is low arterial oxygen content. Anemia is reduced in hemoglobin. Meanwhile, for polycythemia is the increase in hemoglobin concentration. Okay. The cyanosis can be detected when the level of deoxygenated hemoglobin is above 3 to 5. I think that cyanosis can be seen when the level of deoxygenated hemoglobin is above 3 to 5 gram per deciliter. And the intensity of the hemoglobin, it depends upon the amount of deoxygenated hemoglobin rather than ratio of deoxygenated to oxygenated hemoglobin. Okay, for the type of cyanosis, there are three types of cyanosis: central cyanosis, peripheral, and differential cyanosis. Okay, for central cyanosis, so
why the lips so black? Say hello, everybody. Sorry for disturbing the class.
Hello.
hello.
Guys, continue.
Okay. For central cyanosis, it is a pathologic condition caused by reduce in arterial oxygen concentration. So can be detected when the oxygen saturation is less than 85%. For peripheral cyanosis, is there is normal arterial oxygen saturation. Okay. Back to central cyanosis, the cardiac output is typically normal and the patient has warm extremities. For the central cyanosis, it involves the skin, mucous membrane, and the tongue. Okay, for peripheral cyanosis, it involves only the skin. And the cause of peripheral cyanosis is due to increase in tissue oxygen extraction. For example, when in cold temperature, there will be vasoconstriction of the blood vessel, capillary blood vessel, and then there will be stasis of sluggish movement of the blood inside the capillary, and there will be more extraction of oxygen at the peripheral. Okay, then the third one is differential cyanosis. So differential cyanosis is defined as upper half body is pink and the lower half is cyanotic, or vice versa. So in a condition with vice versa, it is called reverse differential cyanosis. Okay, in differential cyanosis, usually patient with in persistent pulmonary hypertension of newborn or severe coarctation and interrupted RTH. So differential cyanosis can be detected by the pre and post ductal oxygenation test. Okay, then factors that affecting the cyanosis. So the first one is hemoglobin count. So in a polycythemic patient, we can detect the cyanosis at a higher level of saturation of oxygen. Meanwhile, in a patient with severely anemic, they may not have we may not detected the cyanosis. A severely anemic patient. And the second one is skin pigmentation. Cyanosis less apparent in a darker skin. And the third one is other physiological factors. So these factors are factors that affecting the oxygen dissociation curve. For the left to shift shift to the left, meaning that the oxygen is there is high affinity to oxygen, so the cyanosis is detected at a lower PaO2. Meanwhile, for the right shift, the cyanosis is detectable at the higher PaO2. Okay. For the mechanism of cyanosis, first one is alveolar hypoventilation. Second is diffusion impairment. Third is ventilation perfusion mismatch. Fourth is the right to left shunting at the intracardiac grade vessel or intrapulmonary level. And the last one is hemoglobinopathy. Okay, for etiology, the causes of cyanosis are divided into non-cardiac cause and cardiac cause. Okay, for non-cardiac cause, so this is just a general rule. For newborn and neonates, they tend to have more cardiovascular cause, especially cyanotic heart disease, more common than pulmonary. Meanwhile, in older children, they tend to have cyanosis due to pulmonary cause rather than cardiovascular cause. Okay, for non-cardiac cause, the first one, according to the mechanism that I explained just now, alveolar hypoventilation. Okay, there are three. CNS depression, for example, like asphyxia, maternal sedation, intraventricular hemorrhage, seizure, meningitis, and encephalitis. So in CNS depression, they will depress the respiratory center and cause alveolar hypoventilation. Then in neuromuscular disease, such as in neonatal myasthenia gravis and phrenic nerve injury. So in phrenic nerve injury, they will cause weakness of the diaphragm muscle and cause hypoventilation. And the last but not least is airway obstruction, like choanal atresia. You can see below the choanal atresia. So choanal atresia is the congenital stenosis of the posterior nasal aperture. So here you can see unilateral atresia, choanal atresia, and this one is bilateral. So there is no communication between posterior nasal cavity and also nasopharynx. So the child tend to breathe more orally instead of using the nose. Then other than choanal atresia, laryngomalacia, macroglossia, and Pierre-Robin syndrome also can cause airway obstruction and can lead to cyanosis. So in the picture at the lateral side, you can see this is a Pierre-Robin syndrome patient. So Pierre-Robin syndrome is classically described as a triad of mandible hypoplasia. So you can see they have small mandible, or in medical term is known as micrognathia. Then they have the second in the triad is glossoptosis. So glossoptosis is posterior displacement of the tongue. So this glossoptosis can cause airway obstruction and can lead to cyanosis. And the third triad is can cause airway obstruction. And in Pierre-Robin syndrome, we can observe the U-shaped cleft palate. This is the pathognomonic sign of the Pierre-Robin syndrome. Then for a second non-cardiac cause is due to VQ mismatch. So in VQ mismatch, so this cause is usually can be seen in the newborn that I listed here. So the first one is respiratory distress syndrome. So respiratory distress syndrome is defined as surfactant deficiency by type 2 pneumocyte. So it is an exclusive respiratory disease of a preterm baby. However, it can also occur in an infant with a diabetic mother. So the function of the surfactant is to reduce the alveolar surface tension, thereby facilitate the alveolar expansion, and thus reducing the likelihood of alveolar collapse. So when there is surfactant deficiency, the child will have more prone more prone to alveolar collapse or lung collapse, known as atelectasis. Okay, then meconium aspiration syndrome. So in meconium aspiration syndrome, usually it occurs due to intrauterine distress that can cause the passage of meconium into the amniotic fluid. It can cause meconium aspiration. And the third one is Addict syndrome. So Addict syndrome is defined as respiratory distress associated with pulmonary interstitial emphysema or pneumothorax or pneumopericardium or pneumoperitoneum or subcutaneous emphysema. So Addict syndrome occurs due to fragile and immature lung cause the alveoli to be burst, and there will be accumulation of air outside the lung. So accumulation of air outside the lung, we can see in pneumothorax, pneumopericardium, pneumoperitoneum, and subcutaneous emphysema. Okay, the first one is transient tachypnea of newborn. It is the most common respiratory distress in newborn due to delay in resorption of lung liquid, especially in infant that is born via cesarean section. So transient tachypnea of newborn, it usually occurs in infant with seizure because in a normal delivery in SVD, there will be compression of the chest when the child is born. Meanwhile, in seizure, there is no compression of the chest to remove the lung fluid. Okay, the fifth one is neonatal pneumonia. Neonatal pneumonia, we have early onset and late onset. The early onset usually caused by infection got from the mother. They got from the mother during intrauterine. For example, when the mother has GBS, then it can transmit the GBS to the fetus. The late onset usually due to nosocomial cause. So neonatal pneumonia can progress to sepsis and then can cause cyanosis. So sepsis, in sepsis there are vasoconstriction of the blood vessels. So can cause the stasis of the blood and can cause cyanosis. Then congenital abnormalities of lung and diaphragm like congenital diaphragmatic hernia and congenital cystic adenomatoid malformation. So in CDH, congenital diaphragmatic hernia, they can impair the development of the lung in utero. So also can cause respiratory distress. Okay, congenital cystic adenomatoid malformation is the overgrowth of the abnormal lung tissue. So the abnormal lung tissue has a fluid-filled cyst. So the abnormal tissue has impact in ventilation function. So it can transfer the oxygen to the pulmonary circulation. Okay, for the third non-cardiac cause is hemoglobinopathy. So there is methemoglobinemia. The methemoglobinemia can be caused. The cause of methemoglobinemia can be congenital and secondary to toxic exposure. So for congenital, the meaning of methemoglobinemia is that the iron inside the hemoglobin is not in a normal form, which is normal form is ferrous. So in methemoglobinemia, there is a ferric state of iron form, ferric ferrum 3+. So this abnormal hemoglobin results in a decreased availability of the oxygen to the tissue, meaning they tend to bind to the oxygen stronger than a normal hemoglobin. So it can also cause can also due to secondary toxic exposure, such as due to methemoglobinemia inducing substance such as in nitrates, exposure to the nitrates. Then the fourth one is diffuse in impairment like pulmonary edema, pulmonary fibrosis, and congenital lymphangiectasia. Okay. So non-cardiac cause in older children is quite different from the newborn or neonate. So here I listed decrease in inspired oxygen. So we can ask the patient any exposure to the burn house, to fire, carbon, so exposure to carbon monoxide, cyanide, and asphyxiating gas can cause cyanosis. Then upper airway obstruction like for foreign body, croup, epiglottitis, and congenital airway anomalies. So below you can see the X-ray of the X-ray in croup patient. So there is special sign we call steeple sign, can be seen in croup. Then the third one is epiglottitis. So we can see tripod position is we can observe in epiglottitis. Okay, for impaired chest wall or lung expansion due to the restricted lung to be from they tend to have less expansion due to pneumothorax, and flared chest. And the fourth one is parenchymal lung disease like asthma, bronchiolitis, pneumonia. Then for cardiac cause, so for cardiac cause, we know that the congenital cyanotic congenital heart disease is can cause the cyanosis. Okay, so for cyanotic congenital heart disease can be divided into decrease in pulmonary blood flow and increase in pulmonary blood flow. Okay, for decrease in pulmonary blood flow, like in tetralogy of Fallot, the most common cyanotic heart disease. So in tetralogy of Fallot, they have 4 characteristics. The first one is the pulmonary stenosis. Second is VSD. The third one is overriding of aorta, and the fourth one is right ventricular hypertrophy. So there will be mixing of the blood. So from the right to the left. Then tricuspid valve anomalies, such as in tricuspid atresia, pulmonary atresia with VSD, and last one is critical valvular pulmonary stenosis. So in critical valvular pulmonary stenosis is a severe form of the pulmonary stenosis. Then in increase in cyanotic heart disease that has increase in pulmonary blood flow. Examples are transposition of great artery, which is ductal dependent, meaning that they depends on the duct to maintain the systemic circulation. The truncus arteriosus is a form of complex cyanotic congenital heart disease. Then total anomalous pulmonary venous return. You can see the picture here. The first picture is a transposition of the great artery. So you can see they have a two parallel circulation. This one is pulmonary circulation, but it's connected to aorta. And for the left sided, it's connected to the pulmonary, and they have two separate circulation. Okay, so the blood that goes to the systemic is the deoxygenated blood from the aorta. So this we can see the cyanosis. And then the picture at this side, you see this is TAPVR, total anomalous pulmonary venous return. So in total anomalous pulmonary venous return is associated with a total mixing of systemic venous and pulmonary venous blood within the heart. So when there is a total mixing, this producing cyanosis. Okay. So there are two major clinical pattern of the APVR. It depends on the presence or absence of the obstruction. So in patient having TAPVR with severe obstruction tend to have cyanosis and severe cyanosis and respiratory distress. Okay, so management of TAPVR is emergency surgical correction. And then F. syndrome. So Essemenger syndrome, it is reverse shunting from. So initially, like in large VSD, they have left to right shunting, but eventually, when there will be a reverse shunting and cause Essemenger syndrome. Then for severe heart failure, can be due to hypoplastic left heart syndrome, coarctation of aorta. So in coarctation of aorta that cause cyanosis is preductal. You can see here, preductal coarctation of aorta, and in this preductal type, or known as infantile type, they depends on the ductus arteriosus, so that the pulmonary trunk, so that the pulmonary the blood from the pulmonary side will go to the systemic. Then the third one is interrupted aortic arch. Okay, so here are the mnemonic for stenotic heart disease. So known as 5T, position TGA, TOF, truncus arteriosus, TAPVR, and tricuspid atresia or tricuspid abnormality. And for the 6T is added due for ton of disease like double outlet right ventricle, pulmonary atresia, many more. Okay. For differential cyanosis, as I described earlier, there will be cyanosis at the lower extremities, meanwhile pink on the upper extremities. So we can see this condition, the differential cyanosis, in a PDA with reversal shine. For example, like in PPHN, severe coarctation and interrupted aortic arch. Okay, for reverse differential cyanosis, so reverse color, meaning that the upper extremities tend to have cyanosis, meanwhile the lower extremities is pink. So it's seen in TGA with either coarctation of aorta or pulmonary hypertension. Okay, so this just listed from the Nelson, the differential diagnosis of neonatal cyanosis. So they divide according to the system, like pulmonary, cardiovascular, central nervous system, hematologic, and metabolic. Okay, for clinical approach, so our aim is to differentiate physiologic from pathologic cyanosis. So physiologic cyanosis is like this one, acrocyanosis. Usually does not indicate pathology and occurs soon after birth that resulted from the vasomotor changes. The second aim is to differentiate cardiac from non-cardiac cause, and the third one is to find the cause which needs urgent treatment or referral. Okay, so for clinical approach, starting with history and do the physical examination, investigation, and management. Okay. For history of presenting illness, so we have to see the onset of the cyanosis. So for the onset of cyanotic heart disease, it really depends on the nature, meaning what is the type of the cyanotic heart disease that the patient has, and the severity of the cyanotic CHD. Then second is alteration in cardiovascular physiology like closure of ductus arteriosus and fall in pulmonary vascular resistance. Okay, for example, like in tetralogy of Fallot, which is the most common types of cyanotic congenital heart disease. So usually the cyanosis, the onset of cyanosis is above 4 months old. However, if the patient has a more severe form of pulmonary stenosis, so they tend to have an early onset of cyanosis. So the onset of cyanosis in cardiac lesion. Then associated symptom, we can ask about fever suggesting the infectious cause or sepsis. Then any trauma, impairment of the chest wall, foreign body, upper airway obstruction, like when they have inspiratory stridor, drooling of saliva, any hoarseness of voice, that's suggesting epiglottitis. Then exposure to this any harmful particle, smoke inhalation can cause carbon monoxide poisoning, and exposure to aniline dye, nitrobenzene, nitrates, and nitrates. So these nitrates derived substance can cause methemoglobinemia. Then birth history, must ask about antenatal history, GDM. So gestational diabetes mellitus in mother can is a risk factor for transient tachypnea of newborn, respiratory distress syndrome, hypoglycemia, and PGA, transposition of grade artery. Then oligohydramnios can cause pulmonary hypoplasia. Pregnancy-induced hypertension can cause pulmonary hypoplasia. Okay, for advanced maternal age, as we know that the child going to have high risk of having Down syndrome, trisomy 21. Okay, drug intake like lithium can cause Epstein anomaly. For perinatal history, we ask about any leaking liquor, suggesting ROM. Okay, then we have to ask about the smell of the liquor. For smelling liquor and maternal pyrexia, GBS positive during perinatal can suggest the neonatal sepsis or pneumonia. Then history of even sedative or anesthetic can cause respiratory distress or apnea. Cesarean section is a risk factor for transient tachypnea of newborn and persistent pulmonary hypertension. Then preterm infant are more prone to RDS, post-maturity, while gestational age and fetal distress can has a risk for meconium aspiration syndrome. Then postnatal, we have to ask about the cyanosis decrease during crying or confirm. So these two points suggesting the choanal atresia. Why the cyanosis decrease during crying? Because when crying, they will open their mouth and breathe to the mouth instead of breathing via the nasal. Then past medical history, ask about if older children ask about prior lung disease, such as pre-existing asthma and condition like bronchopulmonary dysplasia, and ask about also congenital heart disease like cyanotic heart disease. For example, like in tetralogy of Fallot, they can present with emergency condition called hypercyanotic spell. Then in family history, can ask about atopy and eczema or allergic rhinitis can suggest bronchial asthma. Okay, for the physical examination, first we have to determine whether the patient has central cyanosis or peripheral cyanosis. Then we must not be confused with this sign like Mongolian spot. So it's not a cyanosis. The blue tattoo and blue dye. Okay. And then for general examination, we must also look for syndromic phases like in trisomy 21, 18 or 13, and other syndromic phases like Turner or Dijon syndrome, and plus other syndromic phases also we can see in P. robin that tend to have airway obstruction. Okay, then look for any anemia, cyanosis, or any polycythemia. Then look for hydration status to suggest. So if the patient has sepsis, might have cold clammy hand. Okay. Then for vital sign, first is for the temperature. So in newborn or neonate, they tend to have temperature instability. If they have any infection, like in neonatal sepsis, they can have hypo or hypothermia. Then tachycardia and palpate for the pulse. The weak pulse can suggest hypoplastic left heart syndrome. Then if we can also took the blood pressure at four limbs, all of the four limbs, then we can compare the blood pressure. If the blood pressure is higher in the upper extremities rather than in lower extremities, it suggests coarctation of aorta. Then, then for respiratory examination, so in respiratory examination, we look for sign of respiratory distress like tachypnea, flaring, grunting, and subcostal recession. So this is to rule out the respiratory cause, and then can hear the stridor. So we can look for any suprasternal retraction that suggests upper airway obstruction, and we can hear the rills or crackles, any asymmetric breath sound, wheezing, or suggesting lower airway disease like pneumonia or pulmonary edema. Okay, for clear lungs, we can, if the lung is clear, we can think about the cardiovascular cause of cyanosis, like in cyanotic congenital heart disease. Then look for abnormal chest wall movement, like inflamed chest. Then inspect, is there any wound or abrasion, and is there any subcutaneous air with crepitous that can suggesting trauma to the chest wall. Okay, for cardiovascular examination, like usual, inspect, palpate, palpate and auscultate. So these are among several findings. In tetralogy of Fowler, we can find finger clubbing, and the murmur, the type of murmur is ejection systolic murmur due to pulmonary stenosis. Then transposition of great arteries. Can hear the loud S2, loud second heart sound, loud and single second heart sound. Usually there is no murmur, but they may have a systolic murmur due to increase in pulmonary blood flow. Okay. Then abdominal examination, we can just observe to see is there any scaphoid abdomen to suggest congenital diaphragmatic hernia. Congenital diaphragmatic hernia can cause abnormal that reduce in development of the lung during in utero and cause due to underdevelopment of the lung can cause respiratory distress and can cause cyanosis. And then for CNS examination, look for apnea, irregular respiration, yellow bleeding.
Dr. Chandra,
Yes.
you can talk for a while. Okay. How many more slides do you have?
Miss like
How many more slides?
altogether about 50 slides. Currently at 37 slides.
Eh? The one that you sent me very much shorter, right?
Edit yesterday.
Okay, now the problem is, so you just keep your slides there. The thing about all these clinical approaches kind of topics is that they basically want to know whether you guys know how to approach us from a symptom point of view. Now we are talking about cyanosis. The most important thing is whether to differentiate whether it's a cardiovascular thing or a non-cardiovascular thing most of the time, isn't it? The two main things would be a cardiovascular cause or a respiratory cause for the cyanosis, right? Then you got
Yes.
things like others lah. You got things which causes peripheral cyanosis. So the first thing you do is you need to decide whether it's a central cyanosis thing or a peripheral cyanosis thing. Then for work presentation wise, based on history, you go by you go back to your history part. So one more, but okay. So onset, the first thing is that then you decide whether the child has been cynosed since birth.
Yes.
Or the child has a pre-existing condition which may predispose to cyanosis and is now currently more cynosed, or was previously a little bit cynosed and is now progressively the cyanosis has worsened. So kids who have pulmonary hypertension, those who have cyanotic heart disease, isn't it? And then
Yes.
after that, or whether this kid has been totally well and has suddenly turned blue. If it's an acute thing, suddenly turned blue, maybe it's something like a foreign body inhalation, right? Or sometimes it's chemical inhalation. This can also cause cyanosis. If the child has been unwell for a while, a fever, what seems to have to be a lower pulmonary tract infection type of symptoms for a few days and now has turned cyanosis, then you know that the cyanosis is most likely due to a very severe lower respiratory tract infection, whether it's acute bronchiolitis or pneumonia. Change the slide. If it's not clear, you guys just angkat tangan ke or put a message somewhere if any of you still awake. Change the slide. Abe, tukar slide. Okay, wait. One by one, slowly. Slowly.
Right, yes.
Okay, so that's basically it. Change. Antenatal history. So these are more of the causes of cyanosis that you find in neonates, isn't it? Right?
Yes.
So next. So these are the history that you take with somebody who was previously not cynosed and is now kind of cynosed lah. Go next. So central cyanosis, you look at the mucous membrane. So basically the tongue. Mongolian blue spots. I doubt you would mistake it for cyanosis. You're more likely to mistake it in cases of non-accidental injury. You would think it's a bruise rather than cyanosis because you don't get cyanosis that patchy over the back of the extensor surfaces. Tattoos, fair enough. Discoloration, fair enough. Okay, fine. Next. Hypothermia. Okay, next. So once again, most of your symptoms will be most of the time most of the time found in your respiratory examination, but it doesn't actually differentiate whether it's a respiratory cause or a cardiac cause until you complete your examination to include the cardiac examination. Next. Next. Okay, wait. So, I mean, this scaphoid abdomen thing, if you're looking for cyanosis, you see this during right in the immediate postpartum period, isn't it? The first within a few hours, or if it's a small diaphragmatic hernia, then maybe you miss it for the first few days. Yeah. Next. Okay, don't forget that you can also be cynosed because the child is not breathing well. So whether the child is apneic or hypopneic. Yeah. Next. Okay, next.
Thanks.
Not practical, but done theoretically, but like I said, not practical. Next. Abe, explain it, Abe.
This one. Okay, for we can do pre-ductal and post-ductal oxygen saturation. So the aim is to detect the differential cyanosis. Okay, there are pre-ductal we check. So we can either use pulse oximetry or ABG. So pulse oximetry measures SpO2, meanwhile ABG we look at the result of PaO2 or SaO2. Okay, for pre-ductal we measured at the right hand, and for post-ductal measured at the right or left foot. But usually we took at the right foot. Okay, for a normal patient should have a pre and post ductal has the same value of about the same value of the SpO2, PO2 and SaO2. Meanwhile, for patient who has differential saturation or differential cyanosis, meaning that the pre-ductal PaO2 is 10 to 15 millimeter mercury more than post-ductal PaO2. Or they have
From a practical point of view, if you have a baby who's cynos and you want to know whether it's not really also like your PPS and okay, whatever. Anyway, if pre-ductal will be your right hand, right? Post-ductal will be everything else.
Yeah, I
So if
understand.
your pre-ductal is higher than your post-ductal, most likely it's a cardiac cause because the oxygenated blood goes here. The ones where there's mixing because of the PDA goes to the post-ductal areas. So basically that's it lah. Okay. If it's not a cardiac cause, then it doesn't matter whether it's pre-ductal or post-ductal. Okay. So next. Ade, next. So investigations. Fine. So FBC, whether if the white blood cell is high, you think it's more likely an infection. If the hemoglobin is high, the polycythemia and all those things, you would already have known it's a cyanotic heart disease, wouldn't you? ABG septic workup for the causes and also for the sepsis. ECG fine, echo fine, chest X-ray fine. Next, Abby. Next.
There's X-ray of the
Boot-shaped heart, right? Then you're supposed to see ridges on the ribs, which is not very clear here. Next. Snowman appearance, why? Because there is congestion. Okay, next. Egg on a string. Next. Next. Okay. I don't think you guys need to do this. You're just basically doing the causes, right? Next, day.
emergency condition.
Okay, this is for kids. Okay, TOF, okay. Next. Next. Oh, this you need to know. As a medical student, you need to know, but you don't need to be, it doesn't need to be presented here. Just make sure you get the slides and then you read up on it, okay? Next.
For the property.
Okay, I think that's it. Anything you guys want to ask? If you got anything to ask, then just speak up or you just type a message. Now, I actually wanted to show, is everybody still awake? Angkat tangan. I actually wanted to show you guys some videos, but I think dah tak ada masa because I actually need to go and fetch my kid. Sekejap eh. You guys can see the playlist there, right?
Yes.
Okay, I cannot show all. Tell me what you want to see. Because I can only tahan for another 5 minutes, I need to go. Now.
When a child is brought to you with cough, the child breathes out.
The wheezing is expiratory, right? If you listen to it, it's all expiratory. If it is stridor, then it's an inspiratory sound. So it'll be this.
Nah, you don't. Let's see what we got. Is
Diarrhea can hear or not? Because you were shaking your head.
I can hear it.
Wait, I got ready. Inspiratory, so stridor will be right? Wheezing will be expiratory. Unless you ask Dr. Fadil lah, but that's a different thing lah because he's a pulmonologist. But for all intents and purposes, if you're a medical student, all bronchi should be expiratory. Stridor should be inspiratory. Okay? If Dr. Fadil asks you whether it can be expiratory and inspiratory or not, the answer is actually yes. But for medical students, when people ask you whether bronchi is inspiratory or expiratory, your answer should be expiratory. Okay? Stridor is always inspiratory. Muted or not?
Since Monday, the coughing has been worse, and she coughs sometimes so hard she throws up, more than spitting up, but everything. Okay. But not every time.
Yeah. Dr. Paul here. We've got a 2-month-old.
I missed you.
And when I saw them a couple days ago, I'm thinking, well, it was per minute. We do have a pulse oximeter. We checked it. It was 98 on room air last time, 2 days ago. 98. Cough. That's a bronchiolitis cough. And that's probably RSV. We didn't check last time, did we? So I think we should do that. We should just go ahead and make sure we know exactly what we're dealing with. So we're going to do a little nose swab, if that's okay with folks. Yep.
Okay. We'll hold her head up so it stays. That way I'll have better.
Switch hands.
Okay, sure. Okay, all right. You hold her head nice and still for me. Oh. Okay, we're just gonna go up there. Oh, with that booger. There we go. Slurp. Plop, 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 plop. There we go, folks.
The thing about our upper lobe is crackly. Right upper lobe, the patient's right, left, right lower, left. And it's just very crackly up there, but good news is the rest of the lungs are clear.
What does crackly mean?
Well, when you get fluid.
The American way of doing things. Anyway, you can see the effort of the kid, right? The head bobbing up and down a bit. Probably if you lifted up the child from the front, then you could probably see the inspiration and the expiration. The respiratory muscles will be used. it should be that one. I really need to go, but fifth years kan, long time already never go to the ward kan, true? So if you in between streaming your music videos, you can just basically search this up and just see how they do it, okay?
But so I can push it down.
Okay, so
It might be easier to push it down rather than.
Oh, I see what you're saying. Yeah.
Okay,
sweetheart. You are very active. Am I allowed to know how old Adam is? Dad, how old is Adam?
He's.
I said, if you have time, then you just need a revision. You just go to this site, okay, and you search for the examination technique because it's for postgraduate lah. So some of the things they do you might not understand, but more by and large it's the correct way of doing it. So they have neurological CVS, they have the whole range of it lah. So just to refresh yourself, just go and take a look, okay? And then most of the time they use patients so you can see the flow of it lah, okay? And I really need to go right now, so can we just end the class?
Okay, doctor.
Okay, doctor.
Okay.
Okay, thank you very much, doctor.
Thank you very much, doctor. Thank you, doctor.
They have to push back the thing to 11 o'clock. Okay? Bye-bye.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Welcome, bye.
Bye.